evening, and thank you so much for your Director of the Center for Healthcare Affordability. And I just want to thank you for persevering through the cold and the locked door that you saw coming in the room into the community center this morning. I just want to recognize the name that there's a lot of other things happening. Your continued commitment for Minnesotans as a challenges that we're making time for this long. I am going to start us off with just some brief introductions of like how to be a part of today and what the goals are, and then we'll start with some intros. Today's goal is for you all to have some sense of a shared understanding of what is the Center for Healthcare Affordability, what is this group going to be doing, and what is the opportunity that you have to make some impact on healthcare affordability in Minnesota. I want to make sure that everybody's audio, by the way, if you are joined in the room, if you can turn off the audio so we don't hear an echo. Sorry, I'm pausing in the middle to just note a couple housekeeping things. There's some tiny little microphones on here on your table. I think it might be Katie's. Is it this one? Computer? Somebody's making some weird. I wonder if, yeah, can we go, I think Katie's right out by the front door so she can turn off her computer. All right, so goal for today, making sure that you all have a sense of what the center is, what your opportunity is. Importantly, we will get to share with you and invite your input on some work completed to date by the Healthcare Affordability Advisory Task Force. So that is the consumer-driven, employer-driven, purchaser-driven group that's been coming together since September. And you will get to see a little bit about what they've been talking about and weigh in. We also want to gather your input on what else do you want to see over the course of this coming 2 years together. So we're looking forward to more of a discussion about that today. So we have 3 hours together. We will stay to that. We have a break in the middle, but the first half is really about introductions for you all to get to know each other. Introductions from, what is the center, what's the opportunity for this group. We'll also do a look through some data on what is the impact of high healthcare spending in Minnesota on purchasers, on consumers. What do we know about healthcare spending trends? What do we know about healthcare spending drivers? It's going to be a brief overview. We invite your questions. We recognize we won't get to do all of it today, but this is sort of an introduction, and we want to collect questions for future discussion. We'll take a break, and then we'll have more discussion about the Healthcare Affordability Advisory Task Force's work to date and ways in which you can weigh in. I already touched on the mic sitting in front of you. I'd invite you to please just pick them up. If you don't have a mic, just raise your hand and we'll try to make sure that we can pass those around. There are 8 in the room. I'd love to be able to keep 8 in the room by the time we leave. Sometimes it's hard to remember, so just try to keep them on the table. I'd like to also invite you to just say your name so that people on the phone can listen in. And I wonder, can somebody tell me how many people do we have calling in? Do we have some members of the public? Yeah, 32 folks calling in. So thank you for those members joining. We won't be having a time for public comment today, but just know that this is a public meeting. It is being recorded. You are on video. I don't know if you can tell from where you're sitting, but we do just want to urge people, if you're uncomfortable with that for any reason, we can certainly move people around and just let us know. And for members of the public, you are also in the video. If you want to move, my colleague Karen is demonstrating where you could sit if you would like to not be in the video. So you can move over there if that is more comfortable for you. Closed captioning is available for folks online. And if you are having any sort of tech problems, if you're online and you'd like to get in touch with us, you can try to use the chat, or you can use health.affordability@state.mn.us. And we'll be checking that email. Bathrooms are right outside to the right. I think that's everything on the housekeeping side. All right. I want to turn to Carol Backstrom, who is our, there she is. Hi, Carol. She is our Assistant Commissioner of the Health Systems Division, which is where the Center for Healthcare Affordability sits, and really saw the beginning of the Center for Healthcare Affordability. And so we've invited her to just speak a little bit to this group about the opportunity that she sees and that the department sees, and Grateful that she can be here. Thank you.
It is tiny. I suppose it's a little hard to attach it to this giant. I don't think that will be happening. Good morning, everyone. My name is Carol Backstrom, and I am the Assistant Commissioner for the Health Systems Bureau, which, as Alex said, includes the Center for Healthcare Affordability. Congratulations on your appointment to the Provider and Payer Advisory Task Force, and thank you for being here and stepping up. And your time and your perspectives matter. We appreciate it. As you know, the center was created by the Minnesota State Legislature in 2023, and it's the first time our legislature has created a permanent entity that's charged with understanding what's driving healthcare costs and what we can do to slow our spending growth, all while maintaining access, quality, equity, and sustainability. Why is improving healthcare affordability more urgent now than ever? Minnesota has a long history of health reform and task forces, and this time we have a permanent staffed legislative mandate for the Center for Healthcare Affordability. We also have evidence we can look to from other states on their policy progress towards improving healthcare affordability for their residents. I want to acknowledge that we in Minnesota are experiencing the effects of recent federal funding cuts that will likely result in thousands of Minnesotans losing their healthcare coverage. With more people going without insurance, care will become less affordable for everyone. Many of the healthcare organizations you all work for will see sicker patients that cannot cover the costs of their care, leading to more uncompensated services. Health plans will face even more volatility, and health insurance premiums for the insured are likely to rise. These are system-wide issues that we need this group to help navigate in our efforts to make healthcare more affordable. Here are the asks for this task force. You play a distinct and essential role in supporting the Center for Healthcare Affordability and its Healthcare Affordability Advisory Task Force. We are asking that you bring your operational, financial, and clinical efforts to this space. We ask that you think boldly and pragmatically. What could meaningfully change the state's healthcare spending trajectory to improve affordability for Minnesotans, employers, and the state budget? What approaches could improve affordability while also sustaining a strained healthcare system? What is feasible in the near term, and what groundwork is needed for the long-term reform? Lastly, and importantly, we ask you to help pressure test ideas and offer additional innovations. What could work in practice? Thanks, Alex. Oh, we need both. Okay. This is very exciting. I'll do it. There we go. All right. I just feel like I have a voice that carries anyway, but I'll keep using both. Lastly, and importantly, we ask that you help pressure test ideas and offer additional innovations. What could work in practice? What are the risks and unintended consequences? Where do you see opportunity? In Minnesota, we are proud of our high coverage rates, our quality care, and our world-class innovation. We need the leadership of those who deliver and finance care every day to be a part of this effort to improve affordability. Thank you for your partnership. Your work on this task force will help shape a more sustainable healthcare system in Minnesota. Thank you. Leave that on, in fact. Thanks. What a beautiful space, by the way. Isn't this great?
Thank you, Carol. Can people hear me okay if I stand? Okay, I figured there's going to be a couple of people standing at the amplification, so for people in the room, you can hear. This is your roster. Congratulations, just offering your was a process. A lot of interest in this group is nominated in order to across the state, across health plans, as clinicians, as folks of the healthcare system, and as consumers. Make healthcare more affordable and to help the Center for Healthcare Affordability make evidence-informed recommendations. I want to note a couple things about this, and I said this to a couple of you in smaller groups as we led up to today. One is that there are some seats listed here, and that was really a function of getting this group together and recruiting for this group. And so we ask the task force members, for members of the public to understand, to really speak as consumers, as personal, informed citizens, as to bring their own full experiences and not necessarily their own institution. And so we'll be asking folks to not bring delegates, for example. And we'll ask each of these members to speak as from their own expertise. And so you don't need to be sort of limited by your seat. We ask that you speak from your experience. You don't need to speak from the perspective of a delivery member or a health financing administration member, et cetera. I'll also just note that we don't, you also, I want to encourage this group to also just come in with a sense of a learning orientation. And so each of you brings a lot of expertise and a lot of knowledge about what it takes to finance and deliver care. And we want to invite people to come in with a sense of, questioning of, what the opportunity is. And so we invite you to bring your ideas and bring your questions. So with that, I want to go around and do some introductions, and we'll invite you to spend, a minute or two, share a little bit about your background, share a little bit about what led you to commit your time and expertise to this effort. And if you have an ask for this group, like what is something that you hope to see? I will share briefly, and then I'll go around our task force members, and then I'll turn to our facilitators, as well as the Center for Healthcare Affordability team. We have a couple members on the phone that usually gets one member here and one member on the phone. And then we'll also get to hear from the Healthcare Affordability Advisory Task Force's chairs, the co-chairs that are here in person. So thank you to them for joining us. So briefly, I'm Alex Caldwell. I'm the director for the Center for Healthcare Affordability. I have been in this role for 1 year. This is my first time working in state government. I've been working for state government partners as well as nonprofits, clinics, foundations, hospitals, and other healthcare and policy leaders around the country and globally, and have kind of come with this sense of ways in which we can bring data and evidence to policy making. Like that is really what drives me. So I worked at the Global Fund, a big global funder, developing the key performance indicator framework for them to measure their impact of $4 billion going around the world to improve health around the globe. I've led the behavioral health initiatives for the Colorado Health Institute, a nonpartisan group in Colorado. So just to give a sense of like the scope of the subject matter expertise, but the thing that really I care about is ways in which we can bring data and evidence to policymaking, including qualitative as well as quantitative. So that's what I'm excited about to bring to this group and to partner with you on. So I will turn to, I'm going to pick on Sean since you're right here on the left, and thanks for grabbing a mic, and we'll pass it around from there. Thank you.
Thank you. Good morning, everybody. My name is Sean Frost. I've also had some leadership roles related to the integration of social care with healthcare. So social drivers of health, social health. I'm a retired clinician. I'm an internal medicine trained doctor, medical training background. Perspective, I worked for, nearly 20 years as a hospitalist at Regions. And also during that time period, I worked for national in scope hospital managing clinical operations. That organization for a quarter of the time. Some leadership responsibilities for the Physician Professional Association. value hospital medicine. Your deliver care of helping our provider think critically about advancing, revolving reporting. Some of you may know Health Partners Affordability many years ago called we those providers in the community process of constant evolution, and it's kind of exciting. We are trying to get a state where we're surfacing readily actionable signals of cost affordability for care providers in the community to act on. So I mentioned that because that's largely what I think led me to commit my time here to this issue. I've always been interested in affordability. There was a medical student job, affordability, and so that's what led me to one thing I hope to see from the task force is empathy. And what I mean by that is empathy for both the provider perspective as well as the payer perspective when it comes to the complexities, challenges associated with what we collectively need. I think if we're able to lead with empathy, we've got a better chance then of fostering true collaboration. And a better chance then of truly sharing accountability for the results of this task force. If we can do that, then hopefully we'll be well positioned to advance credible recommendations, credible solutions, as well as solutions that are feasible and then hopefully sustainable. But I would like to see the one item.
Morning, everybody. My name is Thompson Derricomi, and I'm the co-founder and CEO of Nice Healthcare. First about Nice Healthcare. Nice Healthcare is a fully capitated virtual plus in-home hybrid model for providing primary care, mental health, and physical therapy. We sell directly to employers outside of any third-party reimbursement. We operate in 14 states, 25 different cities, and we've been operating for about 9 years, saving employers money, saving patients money, and increasing access to critical care. My entire career has been in the healthcare field, for better or for worse. Mostly for worse because the costs keep going up. And previously, I was a healthcare economist and a master's degree in statistics from the University of Minnesota and the System Management. So most of my career was spent analyzing healthcare data. And then when I realized that wasn't working to lower healthcare costs, I decided to actually jump in and start a company to lower healthcare costs. And so really the reason I'm here is the reason I do anything when I'm not with my family or exercising or eating, which is to lower healthcare costs. And it's interesting actually, because I actually want a lack of empathy, and I am not empathetic, towards any of the players. I only care about lowering costs for American families. And as the great Malcolm X once said, by any means necessary, I think is what's necessary to achieve that goal. We can't keep on going the way we're going. And if the choice is the American household, or the industrial complex, I'm going to choose the American household.
Hi, I'm Gita Worcester, and I'm going to try to be brief with this because I feel like I'm old in this group right now. For 13 years, I was working in the Department of Family Medicine and Community Health, running the family medicine residency clinics, and was asked to be part of a small group of individuals that started UCare back in 1984. I retired a couple of years ago, and I take no responsibility for anything happening at UCare today. But what I do want to share is my experience at UCare. We had the largest Southeast Asian population of any plan in the country. At a certain point, we had the largest East African population. We had to be flexible and learn a lot about populations that we didn't know a lot about when they first started coming here. And somewhere in between empathy and rationalization, I counted when I started to think about being on this that I've been on 10 task forces. And when we talk about why I'm doing this, it is so that we can create something that is sustainable, repeatable, and evidence-based if possible to build a trajectory out. Because when I looked at that pile of work that has already been done and replicated every time, it's frustrating to me. And so that's why I agreed to be part of it. And I want to make sure that the most vulnerable of the populations that are here in Minnesota, be they in the metro or greater Minnesota, are considered in how we do this, because they drive up a lot of our costs. And many of the populations that UCare served are the most vulnerable, and they sometimes get forgotten when we're coming up with our solutions.
Somewhat overwhelming. The double mic. Good morning, everyone. Adam Horst, work as the CFO for our Rochester campus of Mayo Clinic. Been there for just under 6 years. Prior to that, I was at Indiana University Health in a number of different roles for about 7.5 years. And prior to that, I worked in state government in the budget office of management and budget for about 8 years under Governor Mitch Daniels at the time. So maybe just highlighting those, but would just say what do those all have in common? They're all not-for-profit sector jobs that I think what really motivates me is how do we make something important for society? How do we contribute in a much bigger way than just thinking about profit? And at Mayo Clinic, we say our primary value is needs of the patient come first. I think that's something I like to think about. That's not just one need, right? That's their health needs. That's obviously affordability topics like this. So really want to keep that front and center. Who are we really here for? And have had opportunities to work in value-based care, ACOs. But I think the thing that excites me the most, and maybe what I'd like to see us challenge ourselves on, is I'm a little afraid we might look in the rearview mirror or at other people who I don't know are succeeding. And I actually think we sit on the precipice of something really exciting that's going on in society with different tools and technologies that might actually enable us to finally break kind of what we would call our pipeline model of healthcare. That's very much kind of, you got to add one increment of resource to get one increment of additional service. And I think we might be at a point where that actually could change. So that actually really excites me. I like us to think about how we maybe think about things not in the traditional way, but maybe in a more transformative way going forward. So, but really appreciate being here and look forward to the conversations.
Good morning, everyone. I'm Tyler Winkleman. I'm a primary care physician and health services researcher at Hennepin Healthcare. I direct our division of general internal medicine, and I lead a group called the Research and Evaluation Data Analytics Core. I've done a lot of work around primary care, behavioral health, Medicaid, and what led me to put my hat in the ring for this, I would say I bring a population health lens and analytical lens to this. So if we're going to be proposing changes, how does this improve our communities? How does this improve the overall well-being of our state? And I think somewhat along the lines of Adam, I hope that we can bring a tremendous amount of creativity. I don't see any way of improving affordability, sort of optimizing the old ways we've always done things in healthcare. And I hope that we can be wildly creative in thinking about what the future of healthcare in Minnesota looks like.
Morning, everybody. My name is Aaron Blomquist. I'm the CFO at Ridgeview Medical Center based out of Waconia. Been there about 6 years, been in healthcare 33 years now. Always on the provider side. And I cringe a little bit sometimes when I, describe my title as CFO, because really the work I've done almost all of my career has been focused on, um, innovation, what we call, value-based care, population health now, but it started in the early 90s as managed care. We had IPAs, PHOs, taking risk, capitation, all of that, and that's kind of got morphed into accountable care, value-based care. And so I feel like I've been working in that for over 30 years now, and I don't like being pigeonholed as a CFO. People think that's more about accounting and financial reporting. So, but I do have a passion for it. Both as a CFO, I recognize that the current model is not financially sustainable for providers. As a patient, I recognize it's not sustainable for consumers. And we do need to do something different. We need to be creative. I really appreciate all the comments that came before because I believe in them all. And so I'm just really passionate about innovation, both in care delivery, and that's going to require innovation in financing of healthcare. And so the two go together, and I think they're important things for us to think about as we approach this work. And I don't know, what do I hope to see from this? There's been a lot of talk about Nobel Awards lately, and I just thought it'd be great if we could do something to win one of those.
Hi, everyone. I am Lynn Nelson, and I'm honored to join this task force. I see a lot of familiar faces around this table, and just a pleasure to be here and working on this. This is really professional and deeply personal to me. I am originally from International Falls, Minnesota. Sorry.
Got it.
I'm originally from International Falls, Minnesota. So as you can imagine, affordability, access, sustainability is a rural issue, but my family's issue every single day. They are driving 3 hours to get shots in their eye for macular degeneration, then turning around and driving back in weather like this every single day. So deeply personal and also professional. And the perspective has really shaped my entire career. So for nearly 20 years, I've been proud to represent Blue Cross Blue Shield of Minnesota as Vice President of Public Affairs. And I've seen firsthand that premiums are expensive because healthcare is expensive. And we have to look at solutions that look at the underlying drivers of cost and not simply shifting who pays. Earlier in my career, I spent over a decade at the Minnesota Department of Health, and that's where I learned how prevention and public health and upstream activities really can mitigate long-term healthcare costs and improve outcomes. So across the work in both state and federal healthcare policy, I know one thing is clear: there's not a silver bullet. It's not just one solution that's going to fix everything. And so we're going to have to think creatively across this group, many groups, to come to a good solutions. And my hope for this task force is that we ground our work in data and facts and collaboration and a shared responsibility to advance solutions that are meaningful and bend the cost curve for all Minnesotans, rural, urban, every sector of Minnesota. And Blue Cross Blue Shield of Minnesota serves 3 million members across all 87 counties. And we're a nonprofit taxable organization as well. And so we're really proud to have that service area and continue that. Oh, I also want to say that I will be in International Falls this weekend running a 5K freezer gizzard blizzard run. So if anyone wants to join, it's supposed to be about -51 with wind chill. This one.
Morning, everyone. I'm Cassandra Beardsley. I'm the Executive Director at Wilderness Health. I've been in that role since 2013. And this started prior to me. There was a group of, at that time, independent hospital executives who would get together, I think, after different Minnesota Hospital Association events and say, we should do something to work together. No offense, Kevin. I think we call ourselves the non-essential group in Eastern Minnesota. That's how you distinguish who's wilderness there. But that group said, we want to do something to work together. And when I interviewed with them, I said, what do you think? What do you want to do? And they said, well, what do you think we should do? And so that's how we started, is really this collaborative group that was saying, okay, we're in this mostly rural region. How do we work together to improve care? And we started in our first accountable care organization as the Minnesota Medicaid IHP, or Integrated Health Partnership, working to improve the care for patients with Medicaid. Very complex conditions, as you all know, underserved, lack of resources, and then you add the rural component to it where people are traveling for care or not traveling for care. And so it was really interesting. I never until that time said kudos to a government agency, but we got a lot of really good information and data from the state of Minnesota. We have used that data to see where we have gaps in care, where are people going for care, where are they not going for care. And through the course of the last 11 years now, we have worked to actively improve care, close the gaps for patients who have less access to resources. So it's really personal, it's really passionate for me. You know, that is what has led me to commit my time and effort to represent a very rural area. Don't forget the underserved. Prior to that role at Wilderness Health, I actually worked for both the largest health plan, which was Cross, and the smallest health plan at that time, which was First Plan in Minnesota, no longer in business. So I have both the provider side and care side. One thing I'd like to see from this task force, others have indicated it's not a Nobel Peace Prize, although that would be great. Radical innovation. It is not sustainable for anyone. You know, patients, providers, health plans, our government, taxpayers, it's not sustainable. And so we have to do something different.
It's a little intimidating having two mics here, but we'll do our best. I'm Kevin Boren. Nice to meet all of you. I'd say my day job is the CFO for the East Market at Essentia Health. That's northern Minnesota, northeast Minnesota, and then the Wisconsin operation. If you don't know Essentia, I think we're the largest healthcare provider in northern Minnesota, headquartered out of Duluth, and that's where I call home. My interest in being here is probably many different pieces. I think the magnitude of the challenge is compelling. I think it really matters to people how access, how affordability goes, equity as well. Social determinants are important to consider along the way. Thinking about upstream health interventions, thinking broadly about a complex issue, I think is really important. I'm excited to learn from others. I think that's really great to be in a room with people and to have all these different minds. I'm just excited to hear people's backgrounds and to understand their perspectives. Specifically, 2 years ago, I completed a master's degree in health economics and policy from the London School of Economics. It really got me interested in some of the social determinants upstream pieces, as well as kind of comparative healthcare system analysis, and I'm hoping that we can do some of that from best practices across the country and other places. What I'm hoping to see out of this task force, I think, would be really specific recommendations that are practical and actionable that we think will really move the mark. I would stress finding things that we know will work, but I think there are some of those things out there that could really help all and make things better for healthcare in Minnesota.
Good morning. My name is Kate Schreck. I'm a family physician for Park Nicollet, and I practice most of my time in primary care, but I do also work in a hospital for us, and I do deliveries for our obstetrical unit. So I see like the full continuum of care for patients, and that is the perspective that I bring to this task force amidst two other things that I think are important. One, which has already been mentioned frequently here, is that my entire time in healthcare has been working with urban underserved communities, and so I think they have particular challenges in terms of access and affordability and making sure that their health outcomes are achieved in the midst of those goals. And secondarily, I do work with the Minnesota Association of Family Physicians, and so I know well the perspectives of many family medicine doctors throughout the state of Minnesota, many who are doing care like I am across the continuum. And I think that we present a unique perspective and opportunity with the information that we have. We work closely with patients. We understand their needs well. We understand often the costs that they're seeing in their day-to-day lives. And there is a lot that we could potentially do for them in working with many of the teams here to figure out like how can we make that better all the way around. So I'm excited to kind of see what work we can do here. I think the thing that I'm hoping for from this task force is transparency. I think a lot of the conversations that I have had in work like this previously has been frustrated by the fact that there are competing interests to some extent. And so thinking about like if we want the well-being of all Minnesotans to be first and foremost and make that affordable, I think we can all be on the same page about that and thinking about how do we bring our teams together toward that goal, knowing the expertise and the information that each of our perspectives holds will be important to ultimately make new pathways forward.
And you're brilliant because I'm going to copy you. The dual hold. I like it. So I'm Amy McNally. I am a practicing GYN oncologist, but also serve as a vice president of surgery for Minnesota Oncology, as well as a national role at people are familiar with US Oncology. I serve as chief surgical officer for the United States for supporting about 22 practices that have surgeons currently in the network. All of those are groups of private practice community-based oncology groups like Minnesota Oncology. I share that because I think a component of my background, probably halfway through my clinical practice, I started in academic hospital system care and then transitioned to community-based private practice oncology. And the thing that I did leadership roles within both systems, but when I switched into private practice, I have the perspective that when you're a physician and you hang your own shingle and you run your own practice and you're making the business decisions in the boardroom, et cetera, it opens up your eyes completely to medicine. And as those physicians in the room know, you're not taught that side of medicine traditionally. Maybe it's different now. I don't think so based on my younger colleagues that have joined the practice. But that perspective of just how fast and dynamic and competitive and challenging the healthcare market is. And I share that because I think that perspective and one end should be physicians should own more of that knowledge because I think that will help the bigger picture, number one. We cannot be agnostic of people's uninsured status, insured status, et cetera. You can't say, I'm just here to take care of the patient. I don't pay attention to that insurance stuff. That cannot exist because particularly in oncology, where I share with people that despite having insurance, which patients, a lot of them don't or will soon not have it, they're still going into medical debt at rates of 50 to 60% when they get diagnosed with cancer. So you cannot separate that out. And how do you address that? Well, you have to understand the healthcare system, and then you have to start getting creative. People have said this around the room. And I think in the oncology, we all in medicine should have been very proactive and dynamic to drive down cost of care forever. In my experience in private practice, because of the competitive market oncology, we've had to do that, or we wouldn't be open right now. And so I've spent a lot of time in my recent leadership understanding how to do value-based care and drive down the cost of cancer care for our practices and with the payers. And I've just that's where my knowledge base and interest in right now. We're in EOM, the only oncology group in the state of Minnesota doing an enhancing oncology model with Medicaid Medicare. So I've had a lot of interest in how to drive down that cost and mechanisms to do so. So that's kind of partly dovetails into like why did I commit my time. I'm passionate about being able to have patients have access to care, period, let alone cancer care. I'm not just focused on cancer, but also to make sure that we are focusing on that patient. I'm kind of with you in that sense that that should be our North Star is those patients focusing that direction. The other thing I would say from ask to the group, I'm a disruptor by nature, and I don't think being a disruptor is always negative. I think it goes along with what other people said. We should be bold. We should be not afraid to change things. We should be willing to look at things very differently. And I think that's the only way we're going to make progress. These are precious.
Okay. Before we move on, we have a couple task force members joining us online. So I wanted to invite Mallory first and then Brittany to introduce themselves.
Good morning. This is Mallory. Can you guys hear me okay?
Yes.
Okay, great. Good morning, everyone. Mallory Kushel. My first full-time role is as a mom of 3-year-old twins, which is why I'm home today with a respiratory virus that I'm trying to spare you all from catching. So thanks for the option to join virtually today. And my second full-time role, I get to serve as the Vice President of Safety, Quality, and Experience at Allina Health. As part of that role and a few other hats, I serve as the Director of Health System Sciences for the University of North Dakota School of Medicine. So hearing Amy, your perspective, we're starting to change the medical school curricula and how do you integrate health system sciences much earlier into medical training. We have a long way to go in this. And, you know, my background, I guess, experience is really around how do we improve outcomes. I believe that we can bend the cost curve by improving outcomes and providing patient-centered care and putting the patient at the center of their care journey, and think that costs will follow, and agree that we need to be disruptive and innovative and think differently, because what we're doing now isn't working for our communities, and we need a sustainable healthcare system that'll prove the test of time here. I think one thing I'm hoping to see from this task force, and maybe I'll choose two. The first is psychological safety. So, like I said, I serve as the Vice President of Safety, Quality, and Experience. I believe that psychological safety is necessary for innovation and disruption. So having this be a safe space where we can ask questions and say, I don't know, and seek to understand, but also really challenge and disrupt and innovate, I think is important to me. And then the second maybe item I'd hope to see from this task force is making recommendations to act. I think in problems this large, it can be really easy to admire the problem and really just try to keep understanding different aspects of the problem. And so how do we help the task force move from admiring the problem to small tests of change, right? Using our quality improvement principles to do something differently, see if it works, and then spread and scale. So great to be here and great to meet all of you virtually.
Hi, everyone. This is Brittany Darlene. I too have small children, and that is why I am home, because they have so kindly shared their respiratory illness with me. So sorry, cannot be there. I am the COO and Director of Quality Improvement for the Minnesota Association of Community Health Centers. We provide policy support, training, technical assistance on financial sustainability, compliance, operational excellence, quality improvement, all sorts of things to our 17 federally qualified health centers across the state. And if you're not super familiar with FQHCs, they're medical, dental, behavioral health organizations who last year served about 168,000 low-income folks across the state. So, of course, many are uninsured and underinsured. Our goal is to help patients overcome barriers to care, so social determinants of health. One of those, of course, being affordability of healthcare. So one of the reasons we exist at all is because healthcare is not affordable. So, you know, that is one of the main reasons why I was eager to participate in this group. You know, as safety net healthcare providers, we are eager to make care more affordable while also improving quality at the same time. We have oodles and oodles of stories of patients who have really awful outcomes because they've delayed care. You know, they come in at the last minute when, you know, their disease has progressed. And I'm sure you all see that too in some of your settings. So, of course, something I hope to get out of this group, or my hope for this group, I echo all of you smart people in the room and on this call. creativity, empathy, ensuring solutions don't inadvertently create disparities for our patient populations. Minnesota has an issue with that. Radical innovation. I echo the PDSA. I'm a QI person by background, also health informatics. So, admiring the problem. Is just not an option anymore, particularly with HR1 coming. If we're going to continue to serve patients and be here, we've got to figure out a solution or many solutions that improve affordability. So hope to see you all next time. Thanks.
Thanks, everyone. My name is Ellie. I agree the stubble situation is weird. So sorry about that. And my palms are sweating just watching them approach me. So sorry for whoever holds this microphone next. My name is Ellie Schultzna. I work for the Minnesota Department of Health. I'm the Stakeholder Engagement and Governance Manager for the center. I have come to the center. I'm a Michigan native. I came to Minnesota for grad school with a brief detour in Spain of 6 years, and then grad school, and graduated in 2020. If that rings any bells, you might be shocked to hear I found myself in infectious disease world, which was unexpected, but really, really awesome. And I wanted to be a part of public health because I felt like it was a field where there was always something new to learn or new challenges. So, I got my wish. And after some time heading up an education and outreach program at MDH, I saw the opportunity to join the center and took it. And I'm so glad I did. I'm very happy to be here. I support both of our task forces. I'm working with stakeholders from all over to understand what to see from the center, what they want to see in Minnesota as a better place to be. I'll admit and acknowledge that these past few weeks have been really hard for a lot of folks, and so I really appreciate that you all could be here. I know that the weather's not helping. It just feels like a lot right now, and I wanted to acknowledge that and just thank folks for being here. And I will ask my colleague Julia to introduce herself, who is also online.
Thanks, Ellie. Good morning, everyone. Nice to meet you all virtually. My name is Julia Stump. You may have gotten some emails from me with our onboarding and getting you all started. I am a project manager with the Minnesota Department of Health. I've been with MDH for going on 2 years now. I have a background in public health, spent a lot of time at the University of Minnesota, and also trained in clinical and basic sciences research. I just want to express that, I'm a resource as well as, Ellie and the rest of our team for all of you to make sure you have everything you need. If you have any questions or issues accessing things or anything at all, we're here and available. And I just look forward to ushering this body along. Thanks.
Right. Good morning, everyone. My name is Julie Sonier, and I'm a senior fellow at Mathematica. And so really proud to be giving an introduction to our team that is supporting MDH with this really important work. So I am based in St. Paul, but Mathematica is a national employee-owned consulting firm that works to advance the common good. So primarily public sector clients. As I said, I'm based in St. Paul. I have a long and deep history working on these issues in Minnesota. So I have the privilege of knowing several of you who are on the task force. And for those of you that I haven't met before today, I look forward to getting to know you as well. But some of that background that I bring to this work is that I worked for many years with MDH in the health economics program, including several as director of that program. I also served for a few years as the director of the state employee group insurance program. So one of the largest purchasers of health insurance coverage for sort of employer-based coverage in Minnesota, and then served for 7 years as the president and CEO of Minnesota Community Measurement. So been working on these issues for a long time. I agree with all of you who have said it is We cannot just admire the problem. And one of the things I have always appreciated about the environment in Minnesota is the spirit of collaboration that people come to the table with. And so I hear that already, and I'm excited to work with you all. And with that, I will ask the other members of the Mathematica team, Henry Siegel and Jessica Genova, to introduce themselves. They are online today. So how about start with Henry?
Hi, everyone. My name is Henry Siegel. I am actually based in Charlotte, North Carolina, but I spent quite a lot of time in the Midwest prior to moving here. I am serving as an analyst. I'm an analyst in Mathematica and will serve as the support staff for both task forces. I have some background in cost with benchmarking and affordability measures here at Mathematica, and I have a series of expertise in data analysis and stakeholder engagement and quantitative and qualitative research. And I'm just really excited to work with you all. And I will pass it off to Jessica.
Thank you, Henry. Hi, everyone. I'm Jessica Genova. I am an analyst and project manager at Mathematica. I am based in Portland, and I am excited to support the center in facilitating and administering both task forces. I have a background in operations and project management and excited to lend those skills to these task forces. Thank you.
Thank you so much. And I want to invite, I think our last introductions are our Healthcare Affordability Advisory Task Force co-chairs, Matt Anderson and Sheila Cascade. And we are pleased to have them in person today. And we've invited them to just share a little bit about the collaboration, speaking of the key word we've heard today. And we'll invite them to come up and just offer some remarks.
Thank you. Good morning, everyone. Really pleased to be here as co-chairs of the Healthcare Affordability Task Force. We're really here in a listening mode. We're not hoping to, we really want to listen to your discussions and ideas. The Healthcare Affordability Task Force has the responsibility to provide formal recommendations to the Department of Health around how to make healthcare more affordable, and we're really looking forward to this group's input into that process and your recommendations. All of you are dealing with real pressures within our healthcare system: aging demographics, underserved populations, increasing input costs, likely loss of coverage for thousands of Minnesotans in the near future. All kinds of things, workforce shortages, you name it, right? That's the world that we're in. That's the world that you all have to deal with every day. And yet within that world, many of you see where the system breaks down, where there are opportunities for savings, where there's waste, that we just don't need to be spending as much money as we do in ways that we do that don't actually benefit people and certainly don't make care more affordable. And so those ideas from the information and the experience that you have, we hope that you will bring into these conversations and into your recommendations. The last thing I'd like to say is that we recognize that it can be very easy as we represent different organizations to be a little bit reactive or defensive about things that make it more difficult for this organization or that organization. And we really want to challenge you to not be reactive as much as possible, and not to push back against strategies and defend the status quo, but rather look at what Minnesota can do. What should we do to make healthcare more affordable? And the organizations will figure out and adapt as they need to as we go forward. And so to kind of shed a little bit of that defensiveness of the status quo as much as possible, and to say, let's do something, as you all described, something that's bold, something that's new, something that really does significantly change the system. Should also say, I forgot to sort of introduce myself again. My name is Matt Anderson. My day job, I teach at the University of Minnesota. I'm not here in my capacity as a University of Minnesota employee. I don't speak for the University of Minnesota, all those kind of disclaimers, so don't hold anything I say against the Gophers. But really am very pleased to be here this morning and super pleased to be able to work with Sheila Cascade.
Well, good morning, everyone. Thank you for introducing yourself, Matt. Thought I was gonna have to be my aggressive self and say, Matt, introduce yourself. So, I'm Sheila Kiskaden. Lately, I've been telling people I'm an elder of the community. And I am trying to communicate that there is really a lot of wisdom in our elders, but there's a lot of wisdom around this table as well. I've had a long career in public policy work, starting as a staffer in Olmsted County. I live in Rochester, home of the world famous Mayo Clinic, Med City, and have had a long association at county government level, working with the people who are underserved. That's really the focus a lot of county government. I had the privilege of serving in the Minnesota Senate for 14 years, and during the time that we were doing major healthcare reform. I left the Senate a long time ago. I served for 14 years. I left a long time ago, went back to my consulting practice where I worked mostly with not-for-profit organizations in Southeast Minnesota and some up here in the Twin Cities as well. And then was elected to the Olmsted County Board and just left that a year ago. I've been out of office for about a year. I have a really strong commitment to the kind of engagement that you represent, where we do cross-sector deep conversations about what our needs are as a state. And healthcare, Gita, you and I have been on task forces. Lynn, you and I have been on task forces. I've been on a lot of task forces over the years on healthcare issues. This is a difficult problem that we keep having to come back because conditions change. Our population changes. And we are in a time in Minnesota that is really, really turbulent. And yet we have some very core Minnesota values around how we're going to accommodate and meet the needs of our residents as to our fullest capacity. But to do that, as conditions change, we have to keep learning and we have to keep modifying. And so we need your expertise. Need the sense that we have is that the task force that we chair will listen closely to the recommendations that you have and the thoughts you have. And we will ask you to test some of the things that we're thinking about and give us your feedback. So today you're going to be hearing about what we've come up with as guiding principles. We want to test those ideas with you. There's so much changing. There's so much changing in Minnesota. There's so much changing at the federal level. There's so much changing of the turbulence within our state. So much changing with the needs of our population as it ages, as it becomes more diverse. And so we really, really want to focus on the deep, pulling from your expertise and the depth of conversation to advise one another, if you will. But we're not really, I think there's so much that you can do in healthcare. And I just want to call out that our intention is that we focus more on the commercial market, that we're really not focused so much on the publicly funded healthcare system at this point as the commercial market. And a really critical question, this center, as envisioned by the legislature, is going to last for many, many years. We're launching something that hopefully can provide a model for how Minnesota gets advice and reaches agreement for many years to come, not just the immediate 2-year future or the next legislative session or whatever party's in charge. But we also do have a duty to come up with some things that are actionable. And so, as we look at doing that, what we choose to work on first will be really important. And it's also going to be important of how we learn to work together, because we really do need to work together and hopefully end up being one voice to the providers, to the employers, and to the public officials as well, all of those folks. So we're very happy to be here with you, and we're hoping that you, as you hear what work we've done so far, you will help us look at what do we tackle first? Where do we begin? What's the ripe opportunity? And I have a degree in organizational development. You often want to start with what's most doable, right? What can you show some early successes? What can we build on? But part of our early successes, in my opinion, is how do we build this center so that it has lasting impact for all of you, for all of us, and for the public policies that we set at the state level and that your organization set as well. So I'm really glad to be here. I'm intending to come to your meetings as often as I possibly can and sit in the back of the room and listen. But through our staff, we will look at how do we collaborate, how do we coordinate, how do you give us feedback, how do we ask you questions, how do we make a real change for Minnesota. So thank you.
Right. And I'm going to jump a little bit ahead so that we can make sure to get you some time for learning a little bit about the data. But I just am appreciating some of the comments that I've heard so far on radical transformation, transparency, collaboration, data orientation, empathy, but also let's not keep the status quo. I'm naming some of that because I think there is a lot of alignment with the Healthcare Affordability Advisory Task Force's interests as well as the centers. So just appreciating the comments that we've heard so far. I'm going to move us quickly through this because we're going to talk a little bit more about the problems at hand. And I know this group knows a lot of these problems, but just to reiterate that the center was created in 2023 by the state legislature with this idea in mind that people are foregoing healthcare. Total healthcare spending is growing faster than wages. That's what we're worried about when we think about what are the problems we're looking to solve and what do we want to see changed. These are some of the milestones, or the North Stars that we want to see change. And the center was created to do a couple of things to get us there. And so what in statute is listed that the center is conducting research in partnership with the Health Economics Program, who you'll get to hear from today, developing policy based on looking at what's happening around the nation and learning from other states and learning from what our experience has been in Minnesota, but also maybe creating something new that doesn't necessarily need sort of a body of evidence behind it, and convening, including this group as well as the Healthcare Affordability Advisory Task Force, but that's 30 seats. Doesn't represent the full extent of the type of engagement that the center is tasked with doing. And so you'll see lots of other ways in which we are getting in front of different groups, patient groups, consumer groups, business groups, all in an interest of testing ideas and gathering solutions. You've seen this charter. I want to get a little bit into the weeds for a minute as to like, what is it going to look like for this group as to how you're going to function. The charter lays out a little more detail, but we'll also come back to and ask you to give us any sort of feedback you have on that to make sure that you have clarity on how to engage. A couple notes on what's in that charter. One, this group consults with, very importantly, the Healthcare Affordability Advisory Task Force. And so we want to see this group working in a partnership, and that's why we've invited the task force chairs, the Healthcare Affordability Advisory Task Force chairs, to come. And we will be also selecting chairs from this group, and so look for that opportunity to offer some nominations so that this group can then collaborate and participate with the Healthcare Affordability Advisory Task Force. There'll also be opportunities for joint meetings at times, so we'll kind of work on that as we go. These recommendations that we hear from both this group and the Healthcare Affordability Advisory Task Force, they're not binding recommendations, they're guiding recommendations. And I want to just call out that you'll see, maybe you can already tell, we're not very formal. We don't plan to run these meetings as like formal sort of up and down votes. And instead, we're asking this group to sort of find consensus as well as share trade-offs and share areas of disagreement with the Healthcare Affordability Advisory Task Force, for example. And the job of the staff at the Center for Healthcare Affordability is to capture that and document that as part of the deliberations of these different groups. Know that they're open to the public, and really importantly, to Sheila's point, but the center was created to ask this group to be thinking about, and we'll ask the same for the Healthcare Affordability Task Force. What can these two groups be doing to equip and position the Center for Healthcare Affordability for long-term success and impact? So we're not going to solve all the things at once, and there may be sort of a stepwise approach in which you want to prioritize different actions first. So what could that look like? This is one sort of illustration as to how we imagine both task forces moving from today through the process of getting to recommendations and strategies. So that could look like going for 2 years studying issues and then coming out with a single report. I'm going to tell you now that I don't want to see that. And so instead, I'd really like to see both task forces learning together on like a deep dive cyclical process. And so that could look like, so far, both of these task forces identifying key terms together. So the Healthcare Affordability Advisory Task Force has offered some definitions for this group to look at, as well as some guiding principles, a framework for how we might organize like, what the problems are that we're really trying to solve for. reviewing the landscape. You'll have a chance to look at some of the data on what is driving healthcare spending. So doing that sort of initial look at building the foundation and then going through and selecting a set of topics for dive, inviting other states to come speak with us, inviting national experts to come and share what's happening in other states and how well different types of policy options are working. And also inviting this group to say, actually, we want to pursue something that's slightly, in addition to or different from the Healthcare Affordability Advisory Task Force, or tweak that group's thinking. So we want to invite this group to think with us about how to get deep on an issue so that then you can then emerge to those. So there's a lot of text here. You have this in your pre-read, and we'll invite some questions about this. But the key point is that we'd like you to think about, let's say by middle of 2026, late spring, early summer of this year, what would it take to get both of these task forces to come together on an initial set of directional recommendations, not with like evaluation plans and sort of full implementation plans, but like, what is it going to take to get to a place where we can say, out of a particular set of areas, these are places where we see an opportunity for Minnesota, and this is what we want the next part of the year to look like. So that's what we're hoping to see this group work together with the Healthcare Affordability Advisory Task Force to do. So I'm moving quickly to invite a little bit of conversation before we get to our data discussion, but I wonder if we could take a couple questions here about what is coming up for you with regard to how the work might flow. What questions do people have?
The recommendations that this group would make for the commissioner to consider, or for the legislature to consider, who are we making our recommendations to?
Good question.
And sort of where should we anticipate they go?
Yes, the flow of recommendations goes from this group to the Healthcare Affordability Advisory Task Force. The center, of course, is listening to those recommendations, but in order for this to really be a consumer, employer, purchaser driven initiative, that's why we came to that Healthcare Affordability Advisory Task Force first.
Got it.
And that's why we're looking to get this group to now act as a consultative partner to that group. So thank you for clarifying that. Yeah.
Alex, it's Alex, right? Yeah.
My name.
Can we talk a little bit about scope? If I recall reading some of the introductory material, scope was really around commercial population. And as you listen to folks around the room talk, there's, massive scope creep, right? You can't tackle that question about commercial costs unless you think more broadly about the entire population, the care continuum. And so is there more definition, more conversation we can have around the scope?
Yep. And the question's from Aaron. The prior question was from Tyler for folks online, by the way. And the question from Aaron was about scope. What is this group scope? What is the Center for Healthcare Affordability scope? And I appreciate that. And I do think there are additional conversations that we want to have even this after the break to invite you all to help us craft that. I would suggest that this group think about that this group recognize that the total cost of care is the scope of the Center for Healthcare Affordability. We will not be successful if we see more people getting access to care, fewer people saying they're foregoing care, but costs continue to climb at a rate that is far greater than the rate of wages, CPI. So we want to see both of those things as our North Stars. But where do we focus our efforts then? I think to Sheila, I think commented on this, what we see other states doing and what we see as the place to start is to focus within the commercial market, across the board in that market, not just because we're going to ignore the rest of the marketplace, but because that's where we see the greatest affordability burden. We see the greatest volatility in pricing and cost sharing. And it's because we see the greatest, we see most people in Minnesota are covered by private plans. And the volatility is most significant. It's also the place where states have had the most control over offering some solutions, policy solutions. So that's why we're suggesting, you'll see in your pre-read, a focus on the commercial market as a place to start. I also want to note, though, that this group in particular is particularly well equipped and positioned to offer places for streamlining and not just offering new policy ideas, but rather can we reduce burden? Can we change the current reporting rules or whatever in order to simplify? So it sounds like I'm saying add new policy. That's not necessarily the case, but within the commercial market is where we want to, we see the most opportunity to start.
Alex Mallory has a question online.
Mallory, thank you.
Yeah, thanks. And the last part of your comment, I think Alex answered it. So my question was going to be, do you envision the recommendations coming from this team to largely be policy focused, or could they also be, efficiency or streamlining focused, or recommend coalitions or cross-sector, work groups on specific issues? And I'm hearing that it's the latter, so we can think a little bit broader than healthcare policy alone.
Mallory, yes, and thank you for asking the question, and we'll invite some additional conversation about that, especially as we talk about the guiding principles today, because I think that will then help us say, well, how much energy do we want to spend on pilot programs or smaller initiatives that are not going to be statewide? So that's a question for both of the cast. Are there any other questions online?
No one has their hand up.
Yes, Gita.
When I look at the information for Greater Minnesota and you look at Medicaid and Medicare being 65, 70% of the revenue streams for them, I'm looking at Essentia. I get that commercial, maybe you have more flexibility, but when you mix in ERISA and all of this, I'm a little confused at why we think we can bend the cost curve without addressing, at least for rural Minnesota, my experience is you can't ignore that because it's become even bigger every year. But maybe I'm missing something.
Mm-hmm. No, I think that's right. And so that's why I would not suggest we only focus within the commercial market because of the issue of different parts of the state looking really different. And therefore, our measures of success are going to be different from parts of the state. But conceptually speaking, I want to be careful to say that we're not just looking to see more people get access to more care at any cost. And so then the question is, well, where do you start? And so let's have a further conversation. I want to make sure to give a chance for our data presentation so that people can see some of those data that you're referring to. And then I'd like to come back to this issue of scope in our broader discussion. That work? All right, I'm going to invite Stefan to jump up, and we'll probably just extend a little bit into or I'll look to how we want.
Yes, and one of the things that will help us sort of stay on time is that it is holding questions about the data presentation until the end of the presentation, because I know there's lots of questions, and we could talk about it, many of these things all day long. So I think our goal is 20 minutes of presentation, 10 minutes of Q&A.
I guess the other thing that'll keep us on time is for me to not go over time. I have 20 minutes for a huge topic, and I want to geek out with all of you about comparative health system analysis and all the work that you're interested in. But my job is to stay on time. My job really is to lay the groundwork for your discussion on healthcare spending drivers, affordability, but it sounds really like you're all already in the know, and I hope I'm not wasting your time. But I'm really looking forward to the conversation. I'm pleased to be here. I'm humbled to be in front of you, where there is so much experience and knowledge, and really excited about where the group goes. I am Stefan Gildermeister. I direct the Health Economics Program in the Department of Health, and talking about data, I'm talking about sort of indicators of the system performance is sort of where I spend my time every day, and I'm excited to talk with you about how this is useful to the discussion of this task force but also the task force that Matt and Sheila represent. Let's see. With 20 minutes, my focus is going to be pretty high level. A lot of more information that we can share with you, and I'm happy to make it available either to ask questions or through the team. Also, take a look at the website if you haven't. There's much more out there. I am going to focus a little bit on spending and how spending and spending growth is affecting individuals, employers, and government. And then close maybe with some thoughts on spending drivers. Before I jump in, I want to say a few things about the health economics program. We are located in the health department, and our role is to inform policymakers with objective evidence as they weigh heavy issues in healthcare access, cost, and coverage. And we do this through data collection, policy analysis, and research, and much of our work is available online. The boundaries are not very firm around access, cost, coverage, and quality. So over the last couple of years, we've looked at telehealth, we've looked at questions of prescription drug pricing and affordability, and have a number of studies in the work that I think have relevance for this group as well. Starting maybe with some data slides. So the healthcare system, as you know better than me, is sort of a web of providers, insurance carriers, intermediaries coming together to serve Minnesotans, patients, and when we sort of look across the web at the expenditures in the state, about $70 billion is spent on healthcare. And is it a big number? Probably. Is it too high? Is it sustainable? Is it inefficient? I think we don't know necessarily from that very number. All we know is if we divide it by the population, well, it's $12,000 per Minnesota residents. If we look at trend over time, we see the amount is growing. We have a doubling of the level of spending every 10 to 15 years. And we experience, considerably higher growth than inflation pretty much every year, with a few exceptions. But if we want to think about what does healthcare spending level and spending growth means, I think we want to look at the impact on individuals, employers, and governments. And I should go back and point out that for those of you who are really interested in digging into the data a little more, there's a link to our chart book series that has much more granular information at the payer level, geographic, in comparison to national trends, etc. But I'm also happy to talk with you one-on-one. So healthcare spending, spending by Minnesota households through premiums and out-of-pocket spending is the single highest item. It is more than the combination of spending on housing costs, utilities, and fuel. It is a big expenditure in people's lives. What does that look like when you look at different people in the healthcare economy? So people with employer coverage, of course, employers support coverage by paying a share of the premium, but employees on their own pay about $7,000, and these are, I think, 2024 numbers. They're a little low on premiums on their own. They're accountable for another $4,000 in deductibles if they have a year of high healthcare needs, and they're responsible for additional out-of-pocket spending. So again, in totality, thinking about the employer's portion, as part of that, people tend to say it's a new car every year that we're spending per person on healthcare on average. For the employer side, maybe it's a technicality, but I think it matters for individuals, matters for employers. Much of this is before taxes. For people in the individual market, there's no tax support in their expenditures. There is premium support, of course, if they're eligible and buy coverage through MinSure, but the picture is roughly the same, $7,000, between $6,000 and $7,000 for this example of an individual who lives in Bennington County, 50 years old, has $7,500 in household income. She would pay about $6,000 to $7,000 in premiums, be accountable for $4,000 in deductibles, and on top of that, depending on point of service cost, pay more in out-of-pocket pay. So significant expenditures, tying back to what I said earlier about household income. So when we ask Minnesotans every 2 years about their experience with healthcare, whether they have coverage, whether they have a usual social care, through a survey that we've conducted since the late 1990s. And what we're seeing is that more people with and without coverage experience healthcare spending as a burden. An increasing number of people report that they, in the previous year, had to forego healthcare because of cost. Now, it is because of the cost that they know they're accountable for, or it is also because of the cost that they fear that they're accountable for. So, on average in 2023, and we've just left the field, so new numbers should be materializing shortly, but in 2023, about 1 out of 4 individuals reported they just chose not to seek care because they were concerned about cost. This is true across people with coverage, but it's of course much more dramatic for people who don't benefit from having insurance coverage. There, half of individuals, more than half of individuals say, last year, yes, there was a time when I couldn't obtain needed care. And that's across the spectrum from mental health, dental health, primary care, surgery, tests, etc. And interestingly, when we break this out differently by looking at people with chronic disease, folks who we want to be able to manage their care, the number is higher than 25%. I'm happy to share that with you. It's not on the top of my mind right now. How does that weigh on people? 1 of 5 Minnesotans aren't confident they could pay their deductible if they had a major healthcare event where the deductible was due, and 1 out of 4 Minnesotans say my insurance coverage does not give me the financial protection in the case of healthcare need that I expect. So it weighs on people. We're talking about a lot of resources moving through the system that individuals are responsible for. It affects healthcare consumption decisions. Employers and governments. So if we look at employers, their primary job is not really to provide healthcare benefits. It's a really important aspect of connecting to the labor market, being attractive, and it's part of the benefit package, of course. But as employers think about spending on health benefits or observe it, the trend in spending, in this case using family coverage as a metric, spending on health insurance outpaces what they can pay in compensation to their engineers, their architects, their support staff. So that is a concern for international competitiveness. Sort of not other countries manage this differently. It's a concern for being attractive to the labor market. And, don't take my word for it. The National Alliance of Healthcare Coalitions conducts a survey of their members, and they quote one of their respondents saying, the current environment is a dumpster fire with unlimited fuel. So, it's individuals and employers saying, oh boy, the methods that we have, the options that we have to adjust to the expenditure growth by changing benefits, changing the contribution, changing the responsibility for spending, it's no longer working. Plenty of fuel. State government is, of course, a payer as well and manages access to healthcare services for Minnesotans. Here we're looking at two time periods. In green is the healthcare portion of the Treasury, and blue is everything else. Green is growing faster than the overall budget. So the portion of the Treasury spending on healthcare has grown from 30% in 2013 to almost 38% in 2023. And if you think about what you've seen in 24, if you know what you've seen in premiums for 25 and 26, this will continue to grow probably at a faster rate. 5 minutes. Ooh. So in 5 minutes, a few words on thinking about cost drivers and how to approach a really complex set of questions. So first of all, of course, we need to understand that healthcare spending, consumption is not uniform. People on Medicare have a different healthcare needs than people in Medicaid, different populations, different healthcare needs, different expenditures. Similar on the right-hand side, as we look at services, different point of service cost, different demand of services. So thinking about both components is really a key part of burrowing down into healthcare spending. But it's not enough to ask, where do people get coverage? And is there a movement? Or what services do people need, or what services do people demand? We also have to understand that healthcare spending ultimately, right, is price times quantity, and quantity is a mix of what services we pay for. But that's not enough either, because price is a function of how much competition there is, how much market power, in other words, entities have, the technology, the pressure of labor cost and input cost inflation, the economy, federal government incentives or limitations. So it's not as simple as price times quantity, and quantity is complex because it is driven by what services do we provide, where do we provide them, how is healthcare consumption shaped by the health of the population, the social media feed that people see, the technology and scientific evidence or lack of scientific evidence that shifts consumption. So in other words, decomposing healthcare spending and thinking about the drivers and understanding or contemplating where the levers are is a complex undertaking. You can approach it pragmatically, and you can approach it methodologically in a sophisticated way. Maybe another look at the same question, a very pragmatic look, just because you have high year-over-year or high growth in a service type doesn't mean that it's a large contributor to spending. So looking at, I don't know, other professional services, the fourth largest service type growing for this period, 6%, but its contribution to spending is really comparatively small because it's a small share of overall spending. The inverse may be true with hospital spending. A small rate, but a large footprint translates into hospital spending being a large driver of spending. So thinking about both components is really important. Here's another way of, another pragmatic, simple way of looking at spending drivers. We're looking here at some known factors, leaving some of the complexity out. Known factor is population growth and inflation, and everything else then becomes light blue. And I think the major takeaway, two major takeaways for me are, look, population changes are not driving a huge part of spending growth. And that makes sense probably to all of you when we're looking at a short period of time, year over year. It might be different as we're looking over a larger period and recognize that the population is aging. So what remains is inflation, and that, of course, incorporates a lot of stuff. Prices is, of course, one component of it, and other factors sort of is much of what we talked about here. Neither of these two slides, of course, address the question, so what is it in prescription drug spending that accounts for spending growth? Which drugs? Which delivery methods? How much of it is market power? How much of it is prices? How much of it is distribution between brand and generics? How much of it is biosimilar? How much of it is the patent system? Or on the hospital side, or on the long-term side, on the long-term care side? Those questions require much more granular granular ways of looking at the data. And that is work that we're in the midst of working on together with the Center for Healthcare Affordability to give you and others sort of more power and make you more dangerous as you think about where the levels are and what needs to change and where the opportunities are. And that's work that we hope to be able to share with you closer to the summer of 2026. So with that, how am I doing with time?
We're good. We're good. I think we will. So we absolutely want to have a chance for people to ask questions, especially clarifying questions. And one of the things that we are well aware of is that the people in this room have a very deep perspective that isn't available from some of the data sources that are available to us about what's driving costs as well, and also more timely information as well. So we know that we will benefit from those perspectives, and that's part of why you're here. But looking for at the moment, how this data on costs and cost trends has resonated with you, any critical gaps in the way that we're thinking about costs and cost drivers that you think we need to address, and then just clarifying questions about the data itself.
And
Lynn. Oh, okay, Lynn and then Amy.
This is Lynn from Blue Cross, and I really appreciate this. I think it's a good basis for us to look at that. From Blue Cross perspective, we've seen an increase in utilization and acuity and pharmaceutical costs significantly in 2025. And so I know that data is not here. And I'm just thinking about the opportunity to bring some of that data to this group and presentations from other folks on our team, like our pharmacy department, that may have some really good deep dives on some of the current utilization we're seeing from our population, which is very big in Minnesota. So just want to put that out there and think about that. But this is a great baseline for this right now.
We appreciate that. Thank you. Amy.
Yes, I guess I think things through storytelling in my mind. And so one of the things that I feel like is kind of also level sets in a sense is none of this is compared to value. There's cost and value. And value is that quality of care. Now, sadly, I think I already know the answer, that the cost have done this and the value of care probably has not, right? Probably has stayed this way, if not down. The other question comes to mind is in Minnesota, as the cost has gone up, where has our under or uninsured population compared to this? And I know that the goal is not to say that we're okay with cost of care doing this as long as everybody has access. I realize that's not what we're saying, but to me, that part of that level set of understanding those, where are we at right now when we talk about quality of care as well as access to care, I think is just a nice foundational way to kind of level set as a group as we're kind of talking about all the things that are important to us.
Thanks. Kevin.
Probably have many data questions and would love some time to kind of develop them further. But a few of the things I'd love to explore, because I think I want to really deeply understand the issue for Minnesota and relative to other states, you know, as we're making these recommendations, just to make sure in a data-based way we're addressing what is the real challenge behind that. Just a few things, access, the percentage insured, affordability, cost of commercial insurance compared to other places. And for exploring affordability, I think the cost of out-of-pocket care, I think, and how that might compare and where those challenges are most acute, I think would be really important to understand. I do think we need to talk about outcomes and quality and balance that picture too. And then trends over time and then really breaking them down. I think pharmacy in particular and nursing home care too as the largest CPI drivers. What are the pieces behind that? So probably a lot more to come, but those are things I'd love to explore in more depth so that we can make sure that our recommendations are aligned with the data and the trends.
Great, thank you. Mallory has a question online, and then Erin.
Yeah, and I'll mostly be redundant here with some of the other comments made from my perspective, also to deeply understand the issue. Having some benchmarking from states that have lower total cost of care would be helpful, just so we can compare, you know, proportions and trends that we're seeing. Are they similar or different? And then maybe better understand why. Also appreciate the comment around balancing measures. How do we improve cost of care and outcomes? I believe we can do both, but need to keep our eyes on those. So defining like what would those measures be, and then maybe getting to the next level of granularity. And I think you said this would be data that's coming this summer for drivers, maybe at the diagnosis level. So when we start to think about hospital care, it's not growing at the highest rate, but serves as the biggest proportion. Are there certain diagnoses, certain conditions, right, that as we think about having the state lean into to think about preventive care differently or treatment differently, are there options for us to consider there? I think that level of detail would be helpful.
Great. Erin, and then I think we will take Erin and then Adam, and then we will take our break.
Great, thank you. I promise I'm really generally a stoic Scandinavian. I've talked more today than I have in the last year. So this won't be a regular thing. I'm just curious. A few times it's come up today. Just information is provided, data is provided, conversation has been focused around comparing ourselves to other states, other experiences in other states and nationally. I'm curious if we're limited to that because I think it's important if we look beyond that. I think we need to look. I'd look internationally. I'd look at other countries. I've spent time in Vienna, Austria, like you did in Spain, and I have a second home in Mexico, and I have good experience in costs in other countries, and I think it would be helpful for us to understand what is impacting costs in those areas, and can we learn anything from that that could influence policy for us?
Great. Adam.
I'm standing between us and a break, so very brief. I think the point's been made. I just want to reiterate cost, access, quality. Like I think that's what we're all after, and I hope. And so I think that's something we need to be thinking about those as balanced scorecard types of metrics. The second piece, which doesn't necessarily come across in some of the data, right, but like anybody in healthcare lives it, is the cost shift, right? I mean, the whole system is designed for government to underpay, so commercial overpay. So if we're looking at just the commercial piece, I think the total cost of care is probably what matters, right? So I appreciate that lens. But I think we need to be careful. You pull on one piece of the picture, I think we may miss the big picture. And then lastly, what comes across to me, and this would be really interesting data, I've seen some data on this, is to look at what's happened in other industries, particularly from a productivity standpoint. If you look at some of the data, what's largely happened in healthcare is we've found ways with advanced therapeutics, technologies, and things that have largely just increased cost, and in many cases actually taken the provider away from the patient. And I actually think we may be at a point where that might be starting to reverse itself with ambient listening and other technologies. But if you look at most other industries that have made significant moves, right, it's because they've been able to dramatically increase productivity, right, through new technologies, right? There's infinitely fewer farmers today, and we make more food than we ever have, right? There's infinitely fewer people that work in steel mills, and we make more steel than we ever have. Healthcare has been on a linear, right, one-to-one path. I think we have to understand that. Otherwise, we're just squeezing the balloon. So I'd like to see some data around productivity and how we think about what other industries have done, as opposed to only looking at ourselves or what other states are doing. I think we need to broaden the horizon in addition to some of the other points made. Thank you.
Great. Well, you all have given us a lot to think about. We do want to take a break. Let's try to come back at 10:50. So that's about like 7 minutes. I realize it's kind of short, but we also are not here just so that we can talk at you. So we want to make sure that we have lots of time for you to sort of offer us your perspectives today. Need to mute the room. Should we mute the room?
Yeah. I like somebody's here.
Oh, hours away.
Right.
Jessica or Henry, can you sort of give us a thumbs up to let us know that you hear us?
Yes, I'm currently on the prescription drug affordability by Council of PDAC for the governor's office. So that's kind of my
Can they hear us?
second state level kind of advisory participation. So, but that's unlike some of these people who are like, I've been somebody task forces. Right. Yeah, that's good. Yeah. And that one is a little bit different.
Don't want the notes out. Yeah.
I'm on the
Because otherwise it's not big enough for me to see what that
only, I
means.
think we're only like 3 or 4 states in the union that are doing that.
All right, welcome back, everyone. We want to get started. We want to start by having Svetlana, who has joined us partway through the meeting, have an opportunity to introduce yourself. And when we did the intros before, we asked people, what led you to join the task force and what's one thing that you hope for as a result of the task force work.
Okay, see if I can figure out the logistics here first. Hi, good morning, everyone. Svetlana Sandberg. I am with the United Health Group. I've been with the company for 10 years now and started on the health plan side, and then worked with our chief medical officer and was running clinical strategy for our Medicare business. I was also leading some population health solutions and bringing in digital therapeutics to enable our clinical and non-clinical navigators. And then was a part of Optum Financial business that provides access to financing for providers and for consumers. And I'm currently with the corporate level team. This is my first task force. So I'm really excited to be here. And I think that one of the reasons that I wanted to join this task force specifically is that it enables us to have this cross-functional discussion across payers and providers, because I would argue that a lot of times we all operate in our silos with our members, our patients, our data, and a lot of guardrails around how the conversations are had. So I hope we can draw this forum.
So we wanted to spend most of the next hour talking to you and getting your perspective, but first we want to catch you up on sort of what the Healthcare Affordability Advisory Task Force has been doing to date. So that task force met for the first time in September and has met 3 times so far. And we don't want to reinvent some of the things that they've done. So we don't want to start from scratch with this group talking about values and principles, for example. We want to share their thinking with you and sort of incorporate your reaction into those. So that's part of what we'll be doing in the next, I would say 15 minutes or so. So in September and October, we had conversations about, we did the data presentations and we talked about definitions and values, and, sort of what information the task force needs to do its work. And then in December, some of the main things that we did was, we talked about a framework for understanding the problem, which we will also talk about today. We talked about that Commonwealth Fund issue brief with the examples of some of state strategies and what other states are doing, and started to identify some priority topics for discussion. So let's start with some of the definitions. So we wanted to make sure that we were all on the same page about what do we mean when we say affordability. And so this is our current working definition. It means that individuals, families, employers, and governments can pay for needed health care without financial hardship or sacrificing other basic needs or priorities. That's our working definition, but we added some detail about what that means specifically from different perspectives. So for individuals, it means that out-of-pocket costs, including their premiums, are manageable and they don't cause people to delay or skip needed care or force trade-offs with other essentials. For employers, it means that healthcare premiums don't grow faster than wages or business revenues, which makes it possible for employers to continue offering coverage sustainably. From a government perspective, it means that public spending on healthcare grows at a sustainable rate that doesn't crowd out other priorities like education, transportation, other basic government services. And from a system perspective, It means that total healthcare expenditures are growing sustainably, and that spending delivers value for the money. So it starts to get at the comments we started to hear at the end of the data discussion, and we'll also see that in some of the values and principles as well about the trade-offs. We also talked about, there are other definitions that are important because we quickly realized we were not using the same words to mean the same thing. So we established some other definitions, which, so importantly, expenditures or spending is the amount of money that's paid to provide healthcare services to individuals. So it might or might not include administrative spending by health plans, depending on the context. Spending is price times utilization. So we've got prices, which is the amount that's actually paid per unit of service, and utilization is the number of units of service provided. And this is a little bit of an oversimplification. So there's nuance to this. Cost is the amount of resources unit of service, and so myself all the time using the words expense, spending, and cost interchangeably. We're going to try very hard in and then charges, as many of you are aware, the list prices of services to do with the actual payments that are made. And so but wanted to make sure that we clarify those definitions. Very importantly, these are the values that are our current working version with the Healthcare Affordability Advisory Task Force. So these are the core beliefs and the priorities about how we do this work. So there's a group of them that are about evidence and innovation, and we've already heard a lot from this group today about the need for innovation and that it be evidence-based. One of the important things here is to make sure that we are considering both incremental and larger scale reforms, that we are building on our strengths, that we want to seek examples from elsewhere of what had worked elsewhere, and that we need to innovate to find new solutions. So it's not true that somebody else out somewhere else already has the perfect solution. We are going to need to innovate, and we can't just copy what someone else has done. And also the importance of sort of evidence and data-informed strategies, but trade-off that is recognizing that some of the innovative stuff, there might not be an evidence base yet. So we are likely to have recommendations that we don't have as much evidence as we would like. Equity and inclusion. And so this, again, about how we do our work to ensure that we engage and listen to all perspectives, centering Minnesotans' individual experiences, making sure that we consider equity and address disparities in cost burden, access, and quality. I didn't realize that this other thing is up on the slide. I want to get rid of it. Okay. Integrity and collaboration. So collaboration to solve problems across multiple sectors. We've heard a lot about that already today, and to ensure that we conduct our work transparently. So, public access to the meetings, meeting materials and recordings are available online, all of that. Yep, got it. And then the last piece that we want to just sort of review as our current working principles are, and we've heard a lot about this already today too, is that we need to make sure that we're not just admiring the problem, that we are working towards solutions that are implementable. It's not okay if we're just generating system-wide savings and that doesn't translate to improved affordability for individual people and for employers. At the same time, I heard someone, it was on this side of the room, said, if we can't just shift costs around between different people, if we are doing that, then we have not accomplished our goals. The solutions that we recommend need to be clear about the roles of different stakeholders to achieve desired outcomes. So we are all part of the problem, and we all need to be part of the solution. And then I think recognizing that there's going to be difficulties and trade-offs with any decision or recommendation, but ultimately the judgment is whether the benefits outweigh the costs of any action. But we shouldn't pretend that there are any just free things that only have benefits. There's always going to be a trade-off. We've heard a number of you today talk about the importance of looking upstream at things like prevention and prevention of chronic disease, especially. And we need to recognize that. So some of the things that are long-run solutions to the cost problem are going to take time, and they may not produce results in the short term. That doesn't mean that they're not worth doing. We also need to remember that the landscape is changing rapidly and account for these changes to the degree possible. So, Adam, I think you talked about that already. It creates both opportunities and challenges, the rapidly changing landscape. And then we need to consider, short-term, long-term effects of solutions as well as potential unintended effects. And I are, listening to people saying like, we don't want disparities to get worse, is a really great example of an unintended effect that we need to be very, very conscious to avoid. So with that background of kind of like where we are in terms of the definitions, the values and principles, we want to sort of stop here and give you all a chance to react to that. So do you have any clarifying questions about those working versions? Or do you see any barriers to moving forward with these versions of the definitions, values, and principles? Amy.
Two comments. This is Amy, sorry. Two comments I would bring. I don't mind because I've been taught by her. All right. I guess two things come to mind about defining affordability. When I look at the stakeholders that are on that page, I would advocate adding physicians, care providers, perspective of affordability. For kind of reasons I commented on earlier, I think as people who are providing care to patients on different levels, we have to have that in a scope of how we practice, and that is following guidelines, best practices that are established by many, many medical experts. And I think that we should not be excluding those as I think that's a key stakeholder group. The other thing is, it's interesting that only under the system is value added in there. The comment of like delivers value for the money. That idea, like we talked about before, others have mentioned, the quality, right? Spending less to get really bad care is going to lead to worse outcomes and more cost, right? And if I think about as a person who pays for my insurance, when I say what's affordable, it's not just preventing me not to go in to get care, right? I want to be able to, what am I paying? I should be able to know that I have access to baseline high quality preventative primary care at minimum, right? Let alone not fearing that if I get cancer, even though I've been paying $500 a month in premiums, that I'm still out of work and I'm the only person working and my family's in trouble, right? I just think there's a basic minimum from an individual that should account for that.
Great, thanks. And I just want to highlight for you, Ellie, that since I'm standing up here, I can't see if Mallory or Brittany has a question. So just flag that if they do. Perfect. Other questions or comments on the values and definitions and principles? John.
Question.
Yeah, so I think it is mostly important so that when we all talk, we sort of aren't confusing ourselves by using the same terms to mean different things. So it is something that I constantly have to remind myself about, but it's really so that we can understand each other well. But this cost piece is important, right? So like, how much is it costing us in terms of labor and administration and malpractice insurance, and understanding from that perspective, I think gives us another view on cost drivers. And I think MDH has some studies coming out on at least the administrative cost side, if that's correct. All right, let's continue. Okay, Mallory, go ahead.
Yeah, maybe just a comment related to the administrative cost side. You know, as I'm reflecting, one of the programs and teams I get to oversee is our accreditation programs, infection prevention and control, quality regulatory reporting teams. And so thinking about just all of the administrative complexities that we spend a lot of resources on in healthcare that don't actually add value to our patients or our care teams or providers or caregivers. And so just thinking about how we might go about quantifying, administrative complexities and where there's a role for streamlining that, that could translate to reduced cost of care overall.
It's a great comment, and that's something that the Healthcare Affordability Advisory Task Force has been very interested in as well. And we anticipate spending probably quite a bit of time talking about that topic.
I just want to say thank you to the Healthcare Affordability Advisory Task Force. I've seen a lot of these types of documents in my years trying to lower healthcare costs, and most of them have been complete trash. And this one is the best one I've ever seen. Normally, I have a lot of issues with these types of things and a lot of complaints and critiques. But honestly, this really resonates with me as someone who spent his entire healthcare career trying to lower healthcare costs. I'm just amazed that you came up with that quickly so that we could start from a credible and reasonable place instead of the usual vitriol we're with trying to solve healthcare.
That's great. We will be sure to share your praise with them. All right, so let's continue.
Let me just interrupt.
Yeah.
I'm sorry about these microphone issues. It was hard for folks in the back to hear. So I just ask if there are 3 amplifying microphones around the room, if you can try to use those, as well as these are the ones that transmit to the people online. So thank you for bearing with us.
Okay. And for the 3 that are around, do they have to turn it on before you speak?
You'll see that I think that one is on. I think that one is off. I think that one is on. So you can turn it easily on and off using the button in the front. Yeah. Thank you for bearing with us.
Okay. So one of the things that became apparent to us in the first couple of meetings of the Healthcare Advisory Task Force is that they really wanted to spend time talking about like the source of the problem. And so in that spirit, this is a framework that we brought to them in the December meeting. It is based on a 2010 report from the Institute of Medicine. That sort of that really resonates with me, in part because there are these 6 buckets of sort of the fundamental source of the problem. And just about anything, not everything that I can think about, I can find a way to put into one of these 6 buckets. So a couple of things for you to know here are, number one, this is not an exhaustive list. And also that we adapted that framework from the Institute of Medicine. So especially some of the things that we listed under the pricing failure bucket are not things that we were all super worried about in 2010, but we're very worried about them now. So the provider consolidation and market power as a source of high and variable prices is one of them. And the issue of pricing of medications is a much larger issue today than it was kind of at the time that framework was created. So if you go to find this original source article, you won't see exactly this because we really needed to think about how to update it for today, but recognizing that it's kind of a useful way of thinking about the problem. One of the other things that's really important to me to make sure that we talk about in terms of this framework is that there's a lot of discussion here about failures, right? So failures of care delivery, failures of care coordination. Those are the words that the Institute of Medicine used. But it is not blaming anybody for a part of the problem. It is the whole system that we all had a part in creating that has created the incentives that lead to missed opportunities for preventive care, missed opportunities for better management of chronic disease so people don't end up in the hospital. So it's really important to me to make sure that everyone here understands we're not blaming anybody for this problem. We all own this problem, and we all need to be part of the solution to it. I was not planning to spend a lot of time on each of the 6 buckets here, but we certainly can come back to this slide and talk about any of them if it makes sense to you. And Amy, you look like you have a
something are these the ones that were narrowed down by the task force to focus on?
This is not yet. So this is really sort of the information that we brought to them to sort of help with the desire to sort of better understand the source of the problem, kind of like the affordability problem. So why do we have these problems with affordability of healthcare? So the list of priority topics that they have been focused on is more sort of like the solution side, I guess, or maybe like individual parts of this, right? So we talked about administrative complexity being one of the things that they would like to dig deeper on. So this is the big picture still. Good question, thank you. We also, in December, there was a desire to not start from a blank piece of paper, from a state policy perspective, to think about, well, what are the things that states can do to help address healthcare affordability, and what are some things that other states are trying? So in that spirit, we brought to the Healthcare Affordability Advisory Task Force, that's a mouthful. I'm going to come, but also if I speak in acronyms, it doesn't exactly roll off the tongue. So we brought this background paper from the Commonwealth Fund just to sort of, as a starting point, again, just so we don't need to start from a blank piece of paper in terms of thinking about what are some things that states can do to address affordability problems. I am going to assume that you read the paper, and so we're not going to like go into each of these strategies. One of the things that I will note is that a couple of these strategies, and kind of depends on how they get implemented. So strategy one is about implementing a statewide healthcare cost growth target. There are several states that have done that. I think it is true that none of the states that have done that are currently meeting those targets. It does not mean that they're not an effective way of focusing attention on parts of the problem. But it also depends on how you get there. So there are easy ways and hard ways to meet cost targets. And there are some things that you can do to meet a cost target that are not things that we think would be a good idea from the perspective of helping people get better health outcomes. So just something to think about there. So potentially very broad in the kinds of things that could happen as a result of that. Population-based provider payment is another one. There's a lot that falls underneath that bucket. So it could address pricing, it could address quantity, it could address prevention. It just kind of depends on what happens underneath there. Many of these strategies are narrowly focused on price, and that's because of the issues that have arisen over the last many years about the role of prices in driving healthcare cost growth. So, strategy number 3, cap provider payment rates, contain growth in prescription drug prices. Provider consolidation is fundamentally a pricing concern. Health insurance rate review, again, is about the price of insurance. So just is a helpful kind of way of framing or how we think about these 10 solutions. A lot of the things that we see states doing are very focused on price. That doesn't mean that this group needs to be very focused on price. It's just helping understand the landscape of what is happening in other parts of the country. Alex, what else would you add as kind of a key takeaway from the 10 strategies?
Yeah, no, thank you. And sorry, I will grab one of the amplifying quickly then here. A couple of thoughts. One is just about the difference between, Amy, your question about what is the scoping, right? And the two slides before, the framework from the Institute of Medicine, I want to be really careful to say that we looked at these policy strategies not as this is a menu of choices and we're going to choose one, right? Or 5 or whatever, but rather to give a sense up to the group, to the Healthcare Affordability Advisory Task Force specifically, to say, this is what other states are trying. And we want to be very careful to go back from that now and say, okay, those might be options. Let's go back to the problems at hand and make sure we are grounding in which problem do we want to solve for, so that we're not trying to sort of match a policy with a problem that is not necessarily the core of the issue that we're trying to solve for. So I want to be careful to not look through these 10 and ask this group, which one looks good or what's missing from this list. I do want to hear from this group, but I think if you go back, Jerry, you'll be able to click back a couple this group or other types of frameworks to just organize our thinking on what is the problem, to come back to this in a more fundamental way than some of the lists, because there's many other lists that you could look at as to like, what are other states trying, value-based payment programs, pilot programs, like, and they're not listed there. So I just want to be careful to distinguish this type of organization of different kinds of failures that we might want to call, like, this is the problem that the center is going to really focus on and that this group is going to focus on. That's where I think the conversation is really meaningful and fruitful. So just want to distinguish those things. And other than that, I'll stop for a second. And are there other, did you want to offer any questions right now, or should we jump ahead?
We are like one slide away from opening up to broader discussion. So I think let's get that, just to also know that, you know, along each of the lines of each of the 10 strategies, part of the information that we also brought to the other task force was about, well, what is Minnesota doing in this area, or what has it done? So for example, strategy number 5, Minnesota has enacted some significant legislation related to oversight of provider consolidation. So, and then we also brought details have been doing is that other states have had about. This isn't like, here's a menu, choose from this list of strategies. It was, and so yeah, I doubt that we will go back to the list of 10 things very often, and it is much more important to go back to the list of, these are the sources of the problem. You know, this is the situation in Minnesota, and these are our opportunities to address it. So the last slide that I have to share with you before we open it up to discussion and getting your perspectives on the, you know, the framework for the problem, as well as the things that the advisory task force has zeroed in on so far, is these are the things that seem to have resonated the most for that group. And Matt or Sheila, I would invite you to sort of speak up as well about kind of where things are at with that group. We have had a lot of discussion about what we're calling non-value added spending. So it's not exactly administrative spending, because it includes activities where there's just a lot of intermediaries and everybody's sort of like getting their piece of the pie. And the question is, you know, how much value are we getting for that spending, and is some of it just sort of pure profit taking? So we talked about private equity, but you know, that's not the only source of places where there's just a lot of entities that are, you know, involved, and questions about the value that we're getting for some of that spending. So it includes, but it is not limited to, administrative complexity. High and variable prices are another place that has really seemed to resonate for that group. And we've also talked about population-based payment that enables providers to address the current system failures. And so this question about, well, providers would like to do X, but we're really prevented by the financial incentives in the system. And what are the approaches that we could take on the payment side that would be more aligned with the outcomes that we want to get, and also enable us to reduce cost growth and improve affordability. And then benefit design is another one. So there was some discussion about, well, you know, administrative complexity is a problem, and like, do we really need as much variation as we have currently on the benefit design side, or are there things that we should be doing on the benefit design side to align consumer incentives with the things that we want, with the behaviors that we want to encourage? And so tiered networks is an example of that. So currently, most networks are, you know, pretty wide open. We don't give consumers too much of a direct signal about cost or quality much of the time. And so the question is, are there things that we can be doing on that side of the picture to help enable decisions that get us better value for our healthcare, for our healthcare dollars? So let me stop there, and we're going to open it up broadly to discussion. So questions or comments that you have about the framework for understanding the problem. So that's the slide with the 6 buckets. Reactions that you have to the initial priorities that the Healthcare Advisory Affordability Task Force is considering, and where do you see this task force having the most to contribute?
Maybe I can offer up some thoughts that crossed my mind while you were speaking. I would say I love the approach of going back to what's the actual problem that we're trying to solve. Regardless of what list we will end up with, coming out of these discussions, I would just offer up some of the dimensions that we may want to consider. So one is, what's the size of the prize? So if we're wildly successful at the end of 2 years or 10 years or whatever it may be, can we actually move the needle on the cost? The second one is, can we take the actions and implement solutions? So is it practical, or is it cost prohibitive, or you get into like all these political things? So something that can be practical and applicable. The other point is around comparing maybe to other states. So let's say price of X in Minnesota went up by 5%, but do we know if it's good or bad? Because maybe the same price went by 10% in a different state, and 5% is not terrible. So just comparison. And then the other point was around use cases. So you mentioned some of the other states have implemented certain policies but haven't achieved the desired outcome. I think looking in detail of what was done, if we think that the problem is still worth solving, could be informative in a way that, like, could we tweak the approach if we still think that there's value?
Thanks. Cassandra.
Thanks. This was really helpful. A couple of things that stood out to me in the challenges. We didn't say anything about patient healthcare literacy. I think that's a really big barrier that we need to talk about. Our system is incredibly complex to navigate. Even if you work in a system and you know where to go and how to go. I think about one of my friends who's a really smart guy, and talking about hypertension. He's like, I don't have hypertension. I have high blood pressure. So, do patients understand their condition and what is the best pathway for them, how to navigate through, how to adjust their health? I think that's a really big challenge. And then I think the note about provider consolidation, I would also add overbuilding. Do we have access resources in some areas and nothing in other areas? So we need to think about, what does that look like from a cost perspective? And then how does that impact maybe some of our smaller providers who don't have that ability to be everywhere all at once, and how do we work together?
Cassandra, can I just add one short comment? So to your point about patient literacy and patient education, I think part of that discussion would be all the recent announcements by OpenAI and Anthropic and Amazon with getting those, consumer-facing solutions, and how does that play a role? And if we think that there is a promise there, is there a way to drive that education?
And accurate information, I would say. Influencers.
Not a fan. All right, Lynn, I think you were gonna. Oh, Aaron.
I just wanted to tag on to what you said. Just there's something about consumer or patient accountability that's really important too. I say accountability, I probably mean engagement. It's going to really be hard for us to impact cost if people still eat really poorly, live sedentary lifestyles, and don't really, they're non-compliant with their care plan, and really just rely on the system to take care of them when they crash. It's going to be hard. So I think considering that in some fashion, being part of this work is going to be important.
Tyler.
One question that this brings up for me is what makes sense at a state level? And as we think about cost containment and say trying to negotiate drug prices or those sorts of things, how much can be done at a state level? Maybe be thinking about more of a regional approach, especially since many systems and payers cover regions as opposed to one state. And I think that'd be helpful, to have a better understanding of, in terms of some of the possible solutions? Like how feasible are they at a state level versus a regional level?
Mallory, go ahead. And then Kevin.
Yeah, appreciate all of the comments thus far. I like the kind of the four macro bullets, if you will, of potential priorities identified to date, and maybe just a couple questions for clarity for scope of them and where, where I'm thinking some actual like tactics or transformation items might fall. So for population-based payment models that enable providers to address current system failures, within that, do you foresee us having discussions or making recommendations about teleservices or at-home services, or how do we really transform care models differently and think a little bit innovatively, or would that, those potential topics fall in a different bucket? And then I have a second kind of similar question.
Alex, do you want to sort of address that question?
Maybe, yeah, and offer your second question too, Mallory.
Yeah, my second question is high and variable prices. I think it's a super important topic in healthcare, and related to that are just, what are different strategies, risk sharing, value-based payment models, et cetera. Would those discussions happen as kind of part of that priority also?
Yeah, so I think these are great questions, and I think of the Provider and Payer Advisory Task Force as uniquely positioned to help advise on some of those issues, Mallory, related to like when we talk about value-based payment, what does that really mean? Can we define that and segment that out into, you named, care model transformation and teleservices, for example, or like different solutions in rural areas versus urban. So yes, and that's kind of a similar theme with your question about pricing and whether that, is it just about price caps? Like in the list of 10, I think price caps are kind of some of the themes that we see in there. But you're suggesting, can we think about the problem of price with different solutions that may look like risk sharing and other kinds of value-based payments? So I think of this group as uniquely positioned to weigh in on those. And so I would invite you to say, could we think about it in different ways? So yes, I think the answer is yes. Those are all within scope.
Sean.
Yeah, I'm thinking about asking a question.
Oh, okay.
But you prompted me maybe to kind of think out loud a little bit. I think these four potential priorities are all fine, but they're too non-specific for me. That's the problem I'm having right now. And they probably mean numerous different things to all of us. So I think this is a good take each one of those topics, right? Some of them might end up being fruitful in regard to translatable into actionable opportunities that might help. Some of them may not, though. So what I was playing on the fourth of my favorite. Yeah, so the title even for this slide is interesting. Potential priority. So it doesn't sound like the healthcare affordability advisory task force has perhaps even gotten down to that next level of granularity to try to figure out within each buckets what might represent a feasible or potentially actionable.
Yeah, and I would say that's exactly right. So the place that we've gotten to so far is like, these are the areas that we feel like we need to learn more about to understand whether there are meaningful subtopics, right? So it's kind of like that pyramid slide that Stefan had about cost drivers. Like every time you answer one question, it just leads to another question. And so we're kind of still working through that process.
Two potential areas to build on. I think there's a lot of really good things in these slides. One area is, I think the stat is only 20 to 30% of health outcomes are impacted by what happens in a hospital or clinic. Right? Therefore, social determinants of health, public health is really significant. And how can we better coordinate those resources around the patients that most need it? I'm not sure what that means, but I think that needs to be a part of our menu of solutions. The other thing that struck me is member copays around benefit design. I guess, they're saying standardize to reduce administrative complexity. I think we need to explore, are they working for people and incentivizing the right healthcare choices? And I think evidence would say maybe it's not currently. And so do we need to think better or differently about how these copays and out-of-pocket costs are impacting health behaviors and maybe make different and better choices around how we put that menu of services in front of patients?
Kate. Oh, and then, I'm sorry, Adam, I skipped you.
No,
Oh,
he's
oh, okay.
and then I'll.
I'm going to be a little biased in my opinion about item number 3 here with population-based payment that enables providers to address current system failures. But I really strongly feel that investing in primary care would lower spending for health across the board. And when I mean invest, I mean like providers that are well supported with a team of people that can help with the social determinants. Like this is my bread and butter. This is what we do every day of our lives, is like help people find how they afford food and find housing and like those things that we know are going to be most important to their health. And in the meantime, I can also work on their diabetes and manage their blood pressure and help people understand like hypertension means high blood pressure. But right now, like we don't have a system that can effectively do that for people. They have a lot of trouble getting access to us. They have a lot of trouble affording to come see us. And so if we can, that would be one of the ways that I think could be a potential path forward in terms of reducing overall spend, is to invest in some of that upstream work and getting creative about what do those teams look like to really address all of the complex things that we know affect health, which will subsequently impact spend.
Thank you. Thompson.
Totally agree with everything you said. So I have a few questions. Some of them might not be able to be answered today. So we're advising the Healthcare Affordability Advisory Task Force, and I've heard a lot of things that don't have anything to do directly with affordability. So I'm just hoping that we can get to consensus in this group about why we're here. Maybe I don't know if that's the objective for today, but I think it'd be important because there's a lot of talk about quality, access, things of that nature. Not saying these things aren't important. I'm just trying to stay really focused on why we're here, and why I joined this group, which is to advise the Healthcare Affordability Advisory Task Force. Now, if they come to us and say, "Hey, we want a bunch of stuff, and knowledge, and we want to make increase access," well, I guess if that's their prerogative, then I suppose we will advise them, as they direct us. But we're taking our direction from them, and so far I'm just going off the of the task force. And I'd like to see this group agree to stay focused on what the task force that we are advising wants us. So that's kind of a question and a statement. Maybe it's like the name. I don't know. And then the other thing is, I just want to encourage us to say the quiet things out loud as a group. And so when we're talking about making things affordable, we're talking about someone's revenue going down. All right, like there's no fancy hand waving. There's no delusion of grandeur that can convince you that it's anything other than that. So if we're talking about someone's revenue going down, we should probably talk about who that is, and what the implications that are. Make sure it doesn't reduce access. Okay, yeah, I can at least buy into that. But we should be talking about it in terms of whose revenue is going down, and when, and where, and why, and what that will translate to in terms of savings or total cost of care, and then ensure that it actually gets to the end patient, at the end of it. That's my second thing, and I'll end after this third one. This third one is, I just want to encourage this group to kind of abstract up to another layer of looking at healthcare. I was talking to Stefan about a long-term belief I have. Everything is commercial. Like Medicare, Medicaid, these are just man-made things. It's not physics. Like someone just said, hey, we're going to call this thing over here Medicaid. We're going to call this thing over here Medicare. Like everything is commercial because it's all funded via the tax. So, even the figures that we saw earlier today are easily doubled. When you add in Medicare, there's no cap on our payroll Medicare. The more you make, the more you're paying into Medicare. 37% of your Minnesota income tax goes towards Medicaid, basically, and serving at-risk population, which is great. I'm not saying it's not great, but we have to look at the total cost, and that's why it is so wide. Of whose ever idea it was to focus on commercial to say, let's start with commercial, because it's the commercial population that is paying 400% of Medicare, and it's also the commercial population that is fully funding all the other care. And so let's make sure we really ground ourselves in what is a total cost of care. It's not just your premium, it's not just your deductible, it's your taxes and also the protection from taxes that employer-sponsored health insurance has, which actually just results in lower tax revenues for the state and the federal government. So anyways, I'll stop because I'll keep going. But I really want us to come back to, are we here to talk about affordability? Or are we here to talk about access?
Someone before me, or am I up?
You're up.
Okay.
Adam.
I guess I'll just respectfully challenge the last view, which is I think when we see in the documents, it clearly calls out what are the unintended or intended consequences of our policies. And access has to be there, right? We could devise the lowest cost system and most affordable system in the world with no access to care.
Correct.
And that would be an absolute failure of this group. So we absolutely have to keep affordability at the top, but I think the two areas, right, that could get sacrificed if all you cared about was cost, right, would be quality and access. And none of us want to have poor quality healthcare or access. It doesn't mean it's primary value of what we're talking about here, but it's the two watch out metrics that you could easily achieve your first goal and still fail. So I guess that would be my perspective on that. It doesn't decrease the priority of affordability. I guess my reaction to the priorities here, it's a little bit of a mixed bag. I get excited when we're talking about, I'll use a medical analogy, when we're talking about root causes or diseases, not when we're talking about symptoms, right? You don't treat symptoms, right? Or you end up in a really bad spot often, right? So what I like is, okay, what is driving up the cost? Prices are an outcome. They're an output. They're an after the fact. You can arbitrarily cap prices on anything. But that's a very different mindset than saying, well, what did you actually do to lower the cost so that price actually works? And we have to actually get into what's actually going to change the cost structure if we're going to have a healthcare ecosystem that actually provides access, high quality care, and all the things we want. So I want to really get into that cost. So things like non-value added spending, I think super important topic, right? Where is there waste in the system? And then maybe just lastly, and I know I'm harping on this today, but I think this is a fundamental issue. Think back, pick any other industry, pick banking. 30 years ago, you had to go to the bank to do anything, right? That was an incredibly labor intensive, inconvenient thing. Who goes to the bank anymore? I mean, almost nobody goes to the bank, right? Everything's done on your phone. Now, that's not exactly the same as healthcare, right? I'm not trying to draw that analogy, but what I'm saying is we have to change the nature in which we operate if you're going to change the cost structure. Just changing a symptom that's 3 or 4 steps downstream, I'm afraid we haven't gotten to the root cause, and we'll end up kind of in the swirl that I think we're seeing in some other places. So I want to get at root causes, not at symptoms of problems.
Great, thank you. Amy. Anybody online? Or I can. No. Okay. So a couple of things that came through my mind as we were going through things. One, I realized that the slides about the strategies or the state policies, just number 4 to comment. I sit on the Prescription Drug Affordability Council. There's already a board and a council that's addressing some of the drug issues. I'm not saying we can't, as a group, go into that as a conversation. It's obviously a big driver of cost of healthcare, but maybe it's just how do we collaborate with those other task force that already exist. So that just kind of came to mind, and we spent a lot of time coming up with a definition of affordability as well. It has multiple members from pharmacy to hospitals to providers, et cetera. It just might be another opportunity to just kind of see what other groups are doing so that we're not duplicating work or learning from the work that others are doing. So that's one thing that stood out. I think other things that came to mind is these ideas of standardization and some of those comments. When I hear those things, I immediately kind of say, is that even feasible in the reality of the world that we're in? I think we have to be cognizant of the fact that the reality of the world is there are private groups, there's hospital groups, there's like all trying to survive and do that. And how can we, or how does the state of Minnesota
then tell every hospital system and every group that they have to standardize something. Is that even a thing? Can you do that? That's a policy, right? So I just want to kind of be realistic that when we're thinking about ideas, can it even be implemented, right? And I'm not saying it couldn't and shouldn't, and that's being bold and all the things I said that I wanted from this group, but I also want realistic, because I think we could go down some of those roads and just kind of shoot ourselves in the foot a little bit, right? It spins to it. My next thing that came to mind, I love your idea of technology, and I was kind of shocked in my master's program I went back to in healthcare that the healthcare industry is the least innovative when it comes to technology. I think if this was 2 years ago, it was like some AI person came and spoke to us, and it was like under 6% of healthcare takes technology to improve not just patient care, believe it or not, but also just operationalize. And we know that people are our most expensive portion of our practices and our hospitals, et cetera. And so how we're going to have to spend to use technology to get that output. But one of the things glaringly we always run into is we are in a world of Epic. And if Epic doesn't do it, or like any technology we as private, healthcare systems want to add, we have this looming thing called Epic that is how do you integrate technology with a company that historically they want to do it themselves, and if they don't think it's important or going to drive revenue, they're not going to work with us as healthcare systems at the state. And most of the healthcare systems in the state of Minnesota are on Epic. So just other things that came to mind if we're coming up with standardization, other implementations, we have things, barriers we need to be aware of.
Thank you. Appreciate that perspective. It's not one of the things that came up in the non-value added spending, but it is another example of just like in the chain of how things actually happen, if it is the cost structure. Electronic health records are just another piece, that we have to pay for, and there's just many sort of suppliers and intermediaries that all have their and to Thompson's point about, well, at the end of the day, if we're going to successful at containing costs, somebody's not going to make as much money as they are making now, and so that is, it just creates challenges, but that doesn't mean that we shouldn't be having those conversations. Anyone else want to jump in right now? Given us a lot, a whole lot, and Amy, I think to your point about standardization, one of the ways that I think about it is that there are a lot of pain points in the system currently, right? And some of the same pain points occur on the provider side and the payer side. So prior authorization, nobody loves that. And so what if there were opportunities to all get in the same room and say, we could streamline the way that we all do this. Not only can you pull out some of the production costs from the system, but you can also improve provider satisfaction, and you can sort of reduce the kind of friction that happens on the patient side when we're waiting for approvals for things. And so that's maybe an example of where an idea about standardization, but I think that one of the keys to that is that it's not for its own sake. It is basically identifying common pain points and then seeing how you can come up with potential solutions to them.
I see that as collaboration or center, right? Yep. Find your what's in it for you, what's in it for you. Oh, there's so maybe I just think
right. And it does not always mean, and it's not the same as the government has to do it, because private sector entities can get together and agree to do things in common ways as well. Mallory, go ahead.
Yeah, maybe just one last thought or comment. We talked about, preventive care and, important investments there that can reduce total cost of care. And also maybe just for that one to bring up just the concept of affordable end-of-life care. We know we bankrupt people every day because we provide really high-cost end-of-life care that most people don't want because they'd prefer to die at home with their loved ones. And so just thinking about different points in the disease trajectory and where we could provide patient-centered care, the right care at the right place at the right time for the lowest cost for the patient. So maybe we'll just add that as maybe a pain point over time that this group or the task force dialogues about, to see if that's an area we could solve together.
Thanks for that.
I have a couple clarifying points. I so appreciate the discussion today. Thank you. And I think this one is on, but it's like very soft. I don't know if people can hear us in the back. Just a couple of notes on some maybe questions I want to just offer some clarity on. One is the PDAB. So appreciating that Amy is part of the advisory group that advises the PDAB, the Prescription Drug Affordability Board. I just wanted to note that the center is also very closely working with that group, with the Prescription Drug Affordability Board, and Matt Anderson is a member of the board. So I just wanted to note that that is a close area of kind of connection, and we're thinking about how to not duplicate and coordinate in any way that we can. And you'll also see that it's not listed, prescription drugs are not listed on this sort of initial take of like what are some of the emergent themes. And I want to be clear that it's not because this list is like the end all, or it doesn't put anything off the table, but because these groups we're only coming together for 2 years, and so like where do you want to start, and then what is it going to look like to like back up and say, okay, circumstances have changed, like these are the reasons we might actually want to come back and add prescription drugs to that list. So just as in one example of ways in which you might imagine this list changing. Second point is I'd love to just come back to Thompson, your question, comment, ask about what is this group for? I will reiterate that the Center for Healthcare Affordability is called upon to look at affordability. So I appreciate your comment, and it actually came up in a couple of the first Healthcare Affordability Advisory Task Force meetings where we started to talk about universal coverage and what other balancing metrics are important for this group, for these groups, and for the Center for Healthcare Affordability to keep in mind. And I want to name those and say yes. And if we do not hold at our core, seeing fewer people report they're cutting their pills in half, or seeing the total healthcare expenditures grow at a rate that's faster than wages, we will not have succeeded. So that may mean that we do see costs associated with like people not having as much choice. We may see revenue decline for certain groups. So I just wanted to name that there are benefits and costs to weigh, but that affordability remains the core that I'd like this group to continue to come back to. And then the last thing I wanted to note, I appreciated, Adam, your comments about non-value spending, and it kind of came up in a couple of places, but I think an ask I would have for this group is to help us and help the Healthcare Affordability Advisory Task Force segment and become more specific. And ways in which I've heard this today is one, regionalization of, Gita asked a good question earlier in the day about like where are people even getting care, what is spending looking like in different parts of the state, and therefore what might that look like in terms of informing different kinds of strategies around the state. End of life care, Mallory, you just mentioned like there's maybe different disease areas we might want to look at. Non-value spending, Adam mentioned this, and I think it feels still so broad to us and to the Healthcare Affordability Advisory Task Force that we would invite this group to help us segment. Are we talking about prior authorization? Are we talking about complexity of different plan types? Are we talking about intermediaries? Are we talking about private equity investment in the marketplace that results in different types of incentives? So I recognize it's a long list, and so it would be helpful for this group to help weigh in and like clarify and segment and really help us get specific. So thank you for letting me just weigh in a little bit on the great conversation.
We'll check and see if Mallory or Brittany have anything to add, or any of the other folks that have been a little bit more quiet today. Although you all have had lots of important things to say.
I don't think I've been overly quiet, but Alex, looking forward to weighing in on the administrative complexity. Lots of thoughts there again, like even in the accreditation side of the world, things that take a lot of resources and don't necessarily improve care and drive up costs. So happy to weigh in there.
Okay. All right. With that, I want to thank you for all of the sort of valuable perspective and input that you've given us today, and turn it over to Alex for some closing comments and next steps.
I feel like I already had my closing comments, but so I won't say much more beyond that. But yeah, so appreciating the conversation today and just for your time. I appreciate our co-chairs, Matt and Sheila, for joining us today in person, and we look forward to inviting this group to nominate some chairs as well. We'll probably do that after the second meeting, so that the next meeting is scheduled for March 27th, and we're finding a location for that. And the next sort of milestone for this group to be aware of is the February 25th Healthcare Portability Advisory Task Force meeting happening in the morning I think that's at the Wilder Center. I realized we don't have that up here, but that's on the website, and you're both not required to join those, but very welcome to do so. So our expectation is with this Center for Healthcare Portability, we'll send summaries to this group. You will also see the materials, like the agenda and that sort of thing, so that you can just track along with the conversation. But again, not required to join in person or join online, but you're certainly welcome to do so. And that is that's our conversation today. Is there any other questions from this group or comments?
What follow-up would you like us to do in the meantime? Gather feedback on specific items, or what would be most helpful?
Yes, great question, Sandra. So I'm thinking we need to do a little bit of work internally to think about what we've heard today to help segment what the Healthcare Affordability Advisory Task Force will be tackling in February. That's some work we're doing obviously now. And in that, there may be opportunities for us to either gather written comment from this group to help us do that. I could imagine surveys and that sort of thing in the future. I don't know if it needs to be for this particular moment. And that would be a way in which we could imagine working together. So there's no immediate ask at this moment. What I would invite you to do is reflect on today's conversation. I'm someone that needs to take a day to just think about what we've heard, and then would invite you to be in touch with us via email. You have my cell phone. Just let's be in open conversation about what you're hearing and the opportunities and what asks you might have for the group. Anything else? Thank you again for your time today. Wishing you a nice weekend, and I would ask that you try to grab one of these guys and just put it sitting in front of you. Make sure it doesn't fall into your bag or something, or fall onto your lapel. Thank you, and thank you again for the conversation today. Appreciate it.
You're free.
Okay, great.